Then I request Dr. Yaksha Mehta sir to speak on ACC and HA guidelines for chronic CAD.
Thank you. Thank you, Dr. Anil Sharma. I thank the organizers for giving me this opportunity to speak on the 2023 AHA-ACC guidelines for the management of patients with chronic coronary disease. The guidelines have described 5 groups of patients who can be said to have chronic coronary disease. One is the group of patients who have been discharged after stabilization of a acute cardiovascular event or a procedure. The second group of patients are those who have stable but ischemic LV dysfunction. The third group of patients are those who have stable angina who have been stabilized on treatment. Fourth group of patients are those in whom are known to have vasospastic angina or microvascular angina. And the fifth group of patients are those who have been found on a screening study to have coronary artery disease. Now, the management strategy, which is advised by the guidelines, is to, as far as possible, to start the treatment first and then evaluate. This is particularly so for patients with ischemic LV dysfunction who can improve a lot with medical treatment. Now, the guidelines also emphasize that there should be a team-based approach for treatment. Social determinants of health should be taken into consideration. And patient education is emphasized. So as finally the decision making is a shared one between the patient and the physician so that the risk-benefit ratios are properly understood by the patients. So the treatment starts with a healthy nutrition, as we all know. Specifically, the guidelines mention that the patients with CCD, the use of dietary supplements like omega-3 fatty acids and vitamin C, D, etc., beta-carotene, have no benefit and need not be given. There is a lot of stress on movement and to prevent the sitting disease that is prevalent here in the present society, and including cardiac rehabilitation for all these stable ischemic heart disease patients. Now, the crux of the treatment, medical treatment, is antithrombotic therapy. And as we see, there is a wide spectrum of patients with wide degrees of recurrent events. So the antithrombotic approaches can be single antiplatelet treatment, dual antiplatelet treatment, dual pathway inhibition, or triple therapy. And the antithrombotic approach has to be tailored to both ischemic and bleeding risks. So who are the patients who require single or who can be advised single antiplatelet treatment? Now, most patients for secondary prevention, stable ischemic heart disease patients, are advised single antiplatelet with low-dose aspirin. Here, the ESC guidelines, as you can see at the bottom, if I can show with a pointer, advise clopidogrel in people who are intolerant to aspirin, especially patients who have vascular disease in other territories like peripheral artery disease or cerebrovascular disease. And of course, single antiplatelet treatment has to be given after 6 months of dual antiplatelet treatment or 3 months after an intervention, depending on the bleeding risk.
You can put Control L on the computer also. Control L laser.
Yes, got it. Thank you. Yeah, got it. Yeah. So the clopidogrel can be given as per ESC guidelines. And after 6 months or 3 months of dual antiplatelet treatment after intervention, depending on the bleeding risk, one can give single antiplatelet treatment. Now, there are some patients who can be benefited with prolonged dual antiplatelet treatment. This is basically from the trial like Pegasus trial, in which patients with previous MI can be given dual antiplatelet treatment either with clopidogrel or prasugrel or ticagrelor or in low dose for more than 12 months up to 3 years. So these are the patients in whom you can give prolonged dual antiplatelet treatment. Also, Vorapaxar, which is not available here, can be added to aspirin and can be given. Now, in a third group of patients are patients of bypass surgery who have been given a 2B recommendation for dual antiplatelet treatment to prevent saphenous vein graft occlusion. Now, what about prolonged dual pathway inhibition? Based on the COMPASS trial, a low-dose rivaroxaban with aspirin can be beneficial in patients who are at high risk of recurrent ischemic events but low to moderate bleeding risk. So after 12 months, there is a decision time when you can decide whether to continue only aspirin or prolonged dual antiplatelet treatment or prolonged dual pathway inhibition. So how do you decide? Dual antiplatelet treatment is beneficial for patients who have had complex PCI for MI in the past, based on the Pegasus trial and DAPT trial. Whereas based on the COMPASS trial, rivaroxaban low dose with aspirin is beneficial for patients with polyvascular disease who are at risk of recurrent events with certain risk factors like congestive heart failure, renal failure, etc. So that is the way you decide what to give beyond 12 months. Now, there is a class 3 recommendation, of course, means there is no benefit to adding clopidogrel to aspirin as a secondary prevention therapy, or adding prasugrel or vorapaxar for patients who have TIA or intracranial bleed in the past. What about triple therapy? Post-PCI patients, especially with atrial fibrillation requiring a full dose oral anticoagulation, for them, depending on the ischemic risk and the bleeding risk, one has to give triple therapy either for 1 month or for 1 week. And after that period, give a P2 white well inhibitor for 12 months or 3 to 6 months, depending on the bleeding risk. And of course, the oral anticoagulants will go on as a single drug for secondary prevention for a long term. What about lipids? The ACC/AHA guidelines have specifically mentioned about triglyceride levels more than 150 in them. Addition of icosapent ethyl may be very useful once the LDL goals are met. And the LDL goal is 70 milligrams, which probably for Indians is not strict enough, and hence the ESA guidelines are a little more applicable to Indians, and which mention that statin treatment should be considered for all patients of CAD, considered as being high risk, and the goal is to reduce LDL-C by at least 50% and to less than 55 milligrams or less than 40 milligrams, depending on the risk. And for beta blockers, the indication is either post-MI in the first year or with LV dysfunction, and patients who have previous MI, whose LV function is normal, without angina, without arrhythmia, or without hypertension, one has to reassess their need of beta blockers after 1 year and probably stop it after 1 year. Then, of course, RAS inhibitors are important for any patient with CAD with LV dysfunction or CKD and diabetes. But even if without those conditions, one can give these drugs, which has a class 2B indication. And colchicine has been given a class 2B indication for secondary prevention. SGLT2 inhibitors and GLP-1 agonists are important drugs which are mentioned for type 2 diabetes and for heart failure. And so medical therapy consists of beta blockers, calcium channel blockers, and ranolazine has been mentioned. One important thing they've mentioned is ivabradine should not be added as an anti-anginal therapy in patients with normal LV function based on a recent study in which harm has been shown. So then we come to diagnose. Now once we have started the guideline-directed medical therapy, the important thing is now to evaluate side by side. So in that, biomarkers are a good help, and then of course stress imaging. Now stress imaging can give us an idea about the severity of disease. However, nowadays, after the ischemia trial, there has been a suggestion to straight away go for CT angiography in stable patients to diagnose left main disease, because in ischemia trial, left main disease was found in 8% of people, and the stress imaging had a very poor predictive value of diagnosing left main disease in these patients. So that could be done. Revascularization, there are 3 important type of patients where revascularization gets a class 1 recommendation, and those are patients with angina despite treatment, patients with left main disease, patients with multivessel disease with severe LV dysfunction, in whom CABG may be very beneficial. And then there are patients with multivessel disease with normal LV function, in whom revascularization may be considered to reduce, to prevent spontaneous MI, unplanned revascularization, or cardiac death. But studies, the ischemia study has found that mortality is not reduced, and hence such patients require a detailed discussion and a shared decision making to decide what to do further. For example, the ischemia trial, who in the Duke score 6 people, that means with severe disease, coronary artery disease, myocardial infarction was prevented to some extent, but all-cause mortality was not prevented. So this has to be brought to the notice. And then, of course, finally, PCI versus CABG, who will benefit of CABG, left main with high complexity, diabetes with multivessel disease with syntax score more than 33, and PCI, if patient is a surgically bad candidate or has diabetes with left main disease, etc. Then the guidelines mention special populations, women. Now the guidelines mention that statins can be given in pregnancy if required after 3 months of pregnancy. They have definitely said no to HRT in post-menopause because of the complications that can occur. Transgenders have been described, and because they receive hormone treatment, they are at higher risk. Young adults, they have emphasized the non-traditional risk factors, which are patients on drugs, stress, coronary anomalies, etc. For the elderly, they have given this formula of 5 M's: mind, mobility, medications, multi-complexity of the elderly people, and what matters most to them, whether the quality of life or the length of life. CKD, high-dose statins for
1 minute.
high-dose statins for contrast-induced nephropathy prevention has been strongly advised, and it has been advised that if CABG is to be done, to do it after an interval of 24 hours after angiography. INOCA has been described in great detail, and distinction between vasospastic angina and angina due to microvascular dysfunction. The treatment and the investigations have been described in detail. For spontaneous coronary artery dissection, beta blockers have been advised as a useful form of treatment, and then patients with HIV, autoimmune disease, cancer also have been described. So I think summarizing, wide variety of chronic disease patients with various degrees of risk are there. Shared decision making is very important, along with the preference of the patient. GDMC should be first started and then evaluate, especially stress testing, and probably CT angiography may be up on the list of such patients. Then various types of antithrombotic therapy can be given, choosing the patients. Role of beta blocker and SGLT2 inhibitors have been specifically emphasized, and revascularization is for angina relief as far as for prognosis. And special populations have been described also in these guidelines. Thank you very much.
Thank you for a fantastic talk, sir.